Go through this chapter relatively quickly because this is an overview of key points in infectious disease mechanisms that you need to be keeping in mind as you continue your learning process. Infection or colonization of microorganisms means that there are microorganisms that are multiplying in or on the host. This is not necessarily a bad thing. All colonizations are not bad. Some are normal. Infection denotes that there's over 300 different species Colonization is not necessarily mad. Colonization is not necessarily bad, although we do think of infection as an over-colonization. There are over 300 different species of bacteria that live within the large intestine that is normal. And we're doing a lot of research now to understand what good bacteria and bad bacteria colonization does within the body. We have bacteria and fungi that live on our skin on a daily basis. The mouth and the pharynx contain many species of bacteria that are normal. It's how this normal balance gets disrupted that leads potentially to infection. And some of the infection or colonization is done by pathogens, and these are all capable of causing disease if your health and your immunity are weakened in some way. Generally, your body can go through its normal homeostasis protective mechanism and get rid of the pathogen, but particularly when your health and immunity are weakened, there are opportunistic pathogens that take place in your body that may otherwise be normal, and they create a disease process. You don't have to know anything about prions. I'm not going to ask you any question. It's so rare that you would even know that. You do need to know that viruses have no metabolic enzymes of their own, and that the whole way that they work is by inserting their genetic materials into the host cell's DNA, and that's why viruses stay in our body. They may go dormant, but they may be reactivated at a later time based on your ability to fight this process of activization. Bacteria are cells that are cells that have no membranes. They can live independently on their own, and they basically use their hosts for food and shelter. It's not like they can't live on their own. They can live on the desktop for days if need be, but what they need the host for is for food and shelter, where a virus needs the host to be able to survive. Bacteria can produce toxins, and these toxins can damage or kill host cells and create all kinds of host immune reactions. Other kinds of infectious agents include mycoplasms, rickets, and chlamydia, and these are just other types of infectious agents. Fungi, the thing to remember about fungi is it requires a cooler temperature than the human body generally. So most types of fungal infections that we see in the body occur on the surface of the body as opposed to inside the body. Parasites, you don't need to know the different kinds. You just need to know that a parasite is a type of infectious agent. The symptomatology of an infection occurs because of the immune response. The immune and inflammatory responses attack the infective agent, causing specific signs and symptoms related to the local damage and inflammation that takes place at the site of the entry. And then there are non-specific signs and symptoms that speak to the systemic inflammation that takes place when they invade the body. There are different kinds of virulence factors that make an infection more likely to cause disease. If there are toxins within the infectious agent, it's more likely to cause disease. And then there are some adhesion factors that help that infective organism stick in the body. And sometimes they have like little shields or evasive factors that help them evade the immune system from killing them. What stage of infection are you in? This is something you'll kind of look at and evaluate as you go through nursing school. The incubation period is where the pathogen is actively replicating. It usually it can be short or long. So, for example, the flu incubation period can be 24 hours, whereas HIV's incubation period can be years. There are usually prodromal signs and symptoms. Remember these. The prodromal is the same. Vague, mild fever, muscle aches, headaches, fatigue, malaise, difficulty sleeping. These are all prodromal kinds of things that could be a multitude of disease processes. In the acute phase, this is where you're seeing the maximum impact of the infectious process. There is rapid proliferation of the pathogen, and the signs and symptoms that are now evident are impacting regular function, When we move into the convalescent phase, it means that your body has actively contained the pathogen and is continuing to resolve it and is decreasing the signs and symptoms that are being seen. And last but not least, you have the resolution phase, where there's total elimination of the pathogen, unless it is a virus. The virus just becomes deactivated. Sometimes we see subclinical or subacute manifestations of infection, and this means that it progresses from acute to resolution without really having signs and symptoms that clinically interfere with normal functioning. Just some word remembering. Itis is related to inflammation. It's not necessarily due to infection. Emia means in the blood. Septis or septicemia means bacterial toxins in the blood. Know that when we're talking about infection, we see rises in certain serology. We talked about this a little last week. IgM goes up in the beginning in the acute phase and then falls. IgG remains elevated even after the acute phase. We don't often look at that, but we can to see how much longer we may have in the disease phase. Important diagnostics when it comes to bacteria and viruses is culture and sensitivities. These take anywhere from 24 to 72 hours to play out. Doing the serology to understand which immune receptor is active, to understand what phase of the disease process you're in. And last but not least, we may look at RNA or DNA sequencing if we're talking about viral infections, but it's rare. Just some generalities about bacteria. Antibiotics kill bacteria by targeting their cell wall synthesis, their protein synthesis, their nucleus, and their metabolism. Bacteria, in turn, adapt. They're adaptable organisms, and they fight back by inactivating the antibiotics, which is what we're currently seeing with all the antibiotic-resistant diseases that are now taking place. They can change the antibiotic binding sites and use different metabolic pathways, or just adapt by changing their walls to keep antibiotics out. So the really important piece about bacteria is they aren't these static organisms that don't adapt and change based on their environments. So we have to keep that in mind as we move ahead. There's a big worry that with all the antibiotic prescribing that we've done, that we've created some superbugs that we won't be able to deal with, and then we'll be back as if we don't even have antibiotics. So there's a new awareness that these bacteria fight back, and we have to be prudent and vigilant in our prescription of antibiotics. Antiviral agents kill viruses by blocking the DNA synthesis so it can't replicate. And that's how it puts that virus into remission. It doesn't generally totally rid the body of the virus. It just puts it into a dormancy. Some of the antibiotic-resistant infections that we see within the hospital that you need to be very aware of and that you will study every single year. Clostridium difficile, or CDiff. It's a gram-positive anaerobic organism that produces toxins and causes diarrhea, and it's related to antibiotic use. The elderly and long-term hospital stays are most prone to having CDiff. It is definitely a nosocomial infection, and it is prevalent among GI surgery. Signs and symptoms are diarrhea that occurs more than 3 in 24 hours, abdominal pain, cramping, and fever. We diagnose this by getting a stool culture, basically. Treatment is to take the patient off the antibiotic and to put the patient in isolation to stop the spread to other people. Herpes is a virus that is transmitted via oral, respiratory, or sexual contact. There are 2 types. Type 1, which is fever blisters that occur on the skin and the mucous membranes. Type 2, where there are painful ulcerations that occur in the sexual organs or the mouth and throat. Signs and symptoms, again, a general malaise, prodromal feeling, lymphadenopathy, which means swollen lymph nodes, a fever, and then culminating in the production of the vesicles. There is an increased white blood cell count during these infections, and we can test for the virus to see if the virus is there. Treatment is to use self-limiting medications like acyclovir to limit the course of the outbreak, but the virus pretty much stays within your body. It's chronic in nature, and our job or our role is to teach patients how to limit the spread to their significant others when they're having an outbreak. Herpes zoster would be what occurs related to people who have had chickenpox at some point in their lives. The chickenpox virus gets reactivated in later years in the elderly, and it creates these deep pain areas along the nerve roots that the patient then has very a lot of pain and itching and lesions. Again, we can't eliminate this. We can only manage it with medications like acyclovir. But for anyone who has had chickenpox, the recommendation is once you get in I think it's somewhere in their 50s, that you get a herpes vaccine to help prevent outbreaks of herpes zoster in the future. Shingles is one of those opportunistic diseases that comes out during times of stress or times where the immune system is compromised, and it's not a fun thing. Last but not least, we have Methicillin-resistant Staphylococcus, or MRSA. You'll hear us talk about this a lot. It is spread via contact, and it is definitely a nosocomial infection, meaning it happens because we spread it in the hospital by not washing our hands most times. Patients that are in the hospital for prolonged hospital stays or have extended use of broad-spectrum antibiotics or are immunosuppressed are at risk. Colonization can happen, and although the colonization is not harmful to the patient, they shed the staph, and it can pose a risk to others. We diagnose by taking a nasal swab and doing a culture and sensitivity from whatever the suspected site is. And we see it as, it shows up as, red bumps on the skin, redness, warmth, swelling. We put these patients in isolation. We use great proper hand washing, and we try to limit the spread and contact. Vancomycin-resistant Enterococcus, or VRE, is another hospital-borne nosocomial infection. It's spread by contact, and it usually starts in the bacterium in the GI tract. Clients who are immunosuppressed or who have invasive procedures such as Foley catheters or central lines, the elderly, people with cancer or chronic disease processes are most at risk for VRE. We see its presentation in the area of where the infection takes place, whether that be in the urinary tract infection or a wound infection. We diagnose it by culturing, and we give meds to eliminate the activity of the bacteria, and we put them in isolation.